capsulectomy on a patient, international patient that comes to me. She had her initial set of implants from the United Kingdom in 2012. So just 12 years old set of implants. She said these were textured 300 cc's, and she had an ultrasound done which showed what is a rupture on the right side. Also on the right side she had what is a grade 3 capsular contracture. So as you can see right here, right side, I cut out the excess skin that helps with the contouring, some tissue that I did not like, so I removed it as well. And you can see what's interesting about her case is, look, this is so hard. This is extremely hard, and I'm going to actually cut into this. And so this is exactly how it was laying. If this is the rib, the implant was literally laying right this. This is towards the sternal side. This is the lateral lower. And as you can see, look at this hard mass. It looks like what is a silicone granuloma. So I'm going to cut into it. But all done in what is an end block fashion. So this is the end block. Complete 100% removal in the end block. And so what I'm going to do is, so it's important to note, this is end block. And so what I'm going to do is, there's no break in the capsule, and I'm going to go in literally from here just to see what it is. And as I go in, this is the nice boundary. And I want to separate this hard mass right here. You can see it's like pancake down, if you will. And so as I go in, clinically, grossly, it's looking like a silicone rupture, and it's solidified right against the chest wall, right on top of the rib. This is what made this case extremely tricky. And the goal is to leave nothing behind that's inflamed. So as you can see, this is part of the inflammation. So I'm going to send this with this tissue. And now this is rock hard solid. As you can see, I'm having a hard time even grabbing it. So as I go in, you can see all of this is inflamed. You can see how thick this is. And look at these small, like literally looks like these nodules. And very, very gross appearing liquid. As you can see, it is liquid. So what I want to do here is, you know, Rodwa, can we get Kelly in here? Or that's fine. What I'm going to do is, I'm going to stay where you are. Just stay where you are. Just stay where you are. Can you give me this basin? So I've got this basin, and I just normally, so let me go ahead and I'm going to go ahead and put this in here because I want to preserve the internal contents. I'm going to lift this up. Okay, so let me go ahead and, is there a kidney basin, like a sterile kidney basin? No, nothing. Okay. Okay, that's fine. That's fine. No, we're good. We're good. So I'm going to go ahead and just cut this open. There's some fluid type consistency. What I'm going to do is, please stay right here. Do you have a syringe by any chance? Yeah. Can you open one 10 cc or 20 cc syringe? So I just want to get this, it's more like a fluid. Can I get another syringe if possible? Because this is fluid. It's not like the molten silica. All right, so what I'm going to do is I'm going to go ahead and put this here and put this here, because remember, this is liquid. This is not like silica. So any liquid around the implant needs to be removed and sent to cytology. So what I'm going to do is I'm going to actually take my scissors and I'm going to cut this open. And you can see right here, this is the implant. And this is exactly what we see in the inside. Look at this. And remember, the pathologist is going to look at it. All contain en bloc. Look at this, has a brown tinge to it. And look at these small maggot-like eggs, if you will. They're going to look at it as well. And I'm going to cut this open. Remember, this is what I was saying, like a hard mass. I'm going to cut this open. And so this is a ruptured silicone. So you can see how flesh type consistency this is. So I'm going to go ahead and put the specimen here. This is the pathology specimen. Now I want to go ahead and pull this out. So this is indeed what is a textured implant, literally disintegrated. Look at the yellow color of it. And you can see the inside. There's no fluid. What I'm going to do is I'm actually going to go ahead and put this here. I'm going to take some more of this fluid so that I have all of it. So I have a good representative sample. So this is your textured implant. Remember, any fluid around any implant, be it saline or silicone, and especially textured, it is a red flag for lymphoma. Now, I'm not saying it is, but we'll see with the CD30 analysis. And they do analysis here, and they do analysis with the fluid, and we'll know what this is. And again, look at this consistency right here. What I'm going to do is I'm going to change my top glove, and I'm going to focus on the left side. And so this is the left side. Now, the one thing I want to mention here is, as I was dissecting, it was literally super glued. You see this small area right here? So there was a break in the capsule. I'm just going to go in to show. There was a small break in the capsule, like 3 millimeters, 3.5 millimeters. So as soon as that happened, inevitably, because I was dissecting against the rib, and you can see this is the rib right here. This is the cartilage of the rib. So you see this is the cartilage of the rib, cartilage of the rib. I was able to plug this, if you will, so that now I can continue to dissect. And this sticks, as you can see, this sticks and prevents spillage. And as you can see, overall, there was no spillage. This is some other tissue that I'm going to send. There was no spillage, and you can see some areas so thin, some areas thick. And now I'm going to go ahead and cut this open. I will utilize this area. And again, to my surprise and to the patient's surprise, these are just 12-year-old set of implants. And lo and behold, look at this rupture. I was not expecting this side to be ruptured. Remember, the ultrasound had picked up just the right side. And so you can see she's an international patient, and she came to me, and she had seen multiple other consults. As you can see, none of this spilled into the chest. I'm going to cut these bands out that are holding the implant. And you can see all of this is contained. None of this spilled into the chest. And that's the whole beauty of the surgery. And as you can imagine how relieved the patient is going to be that these are not in her. And these were just 12 years old. And this goes on to showing you that the implants are not meant to be in the body forever. And very indurated hard. You can see some of the, you can see my blue glove. So if I take this ruler and I go in, you can actually read 6, 7. It's so transparent. No matter what, the entire capsule must be removed. You don't want to leave this behind. And look at this completely disintegrated, what's supposed to be the safer, better gummy bear implant, right? It is gummy for sure, but not safe. So the take-home message is any fluid around any saline implant, silicone implant, or textured implant outside or inside must be sent to cytology to rule out the BIA-ALCL, which is the breast implant associated anaplastic large cell lymphoma, BIA-SCC, which is the BIA breast implant associated squamous cell cancer. Remember, this cancer is rare of rare. Only to date, 1,233 cases or so have been identified all over the world. So this is extremely rare, but this needs to be done in order to rule it out. And the surgery of choice is to remove all of that capsule completely, definitively, sincerely, so that there is no capsular burden remaining behind. And that is the essence of what is explant surgery, so that there is no doubt that there is BIALCL, which is again very rare of rare. It's like getting struck by lightning, and even more so rare. But this is where the workup needs to be done. So the implants will be returned to the patient so that she knows what was inside her. The capsules, the right and then the left, will be sent to pathology to rule out the BIALCL, CD30 analysis, squamous cell cancer, lymphoma, CD30 analysis. The fluid will be sent separately to cytology to rule out the BIALCL, CD30 analysis. Cultures have been done from the chest for aerobic, anaerobic, and fungal. And most importantly, we'll see how the patient bounces back to a normal state of good health. The implant was below the muscle, super glued to the chest. It was a very tedious, meticulous dissection. She did not need drains. She did not need a lift, given the way I reconstructed her. And we'll see post-op, as you can imagine, how well she's going to do minus the silicone toxicity. Implants are not meant to be in the body forever. She had the symptoms of breast implant illness. The implant and capsule, one must always assume that the implant is ruptured to prevent. Otherwise, I did not know the left side was ruptured, and even when I did find out, I was able to contain it such that none of the silicone spilled into the chest. This is Dr. Khan, Executive Plastic Surgery.